Hello everyone, we are from Group 5 and will present medical nutritional therapy for burn wounds. Let's begin with the pathophysiology of burn wounds. Burn is an injury to skin or other tissues that are caused by thermal, radiation, chemical or electrical contact. Heat from burns causing protein denaturation and coagulative necrosis of various layers of skin and underlying tissues. Therefore, the body tries to maintain homeostasis by initiating a process of contraction, retraction, and coagulating of blood vessels immediately after a burn injury. There are three types of depth burns. First degree of burn affects only the dermis, while the second degree of burns affect the epidermis and dermis. For the third degree, it reaches to the fat layer beneath the skin that can destroy nerves and cause numbness. Moving on to the diagnosis and treatment. Diagnosis is based on severity of burn by assessing the degree of burn including their depth and percentage of body surface affected. The severity is influenced by the extent of damage to the body. The extent of burn is usually based on the rule of nines. Combination of those classifications determine the degree of burn injury such as partial thickness and full thickness. For the treatment, the goals of the treatment is to control pain, remove dead tissues, prevent infection, reduce scarring, and regain functions. Example of medical treatment is to encourage the healing include water-based treatment, intravenous fluid to prevent dehydration and organ failure, burn cream and ointment, dressing, and tetanus shot. Moving on to the possible nutritional consequences of the burn injury, mechanical ventilation is used in burn patients who have been in a smoked environment for prolonged periods of time. Burn injuries cause significant metabolic derangements that make nutritional support uniquely important and challenging for burn patients. Many burn patients are able to eat food, and nutritional counseling should focus on selection of high protein and calorically dense food and fluids. A diet high in calories and protein supports the immune system to decrease the risk of infection, helps wound heal faster, maintain muscle mass, and minimize weight loss to support rehabilitation. Hyperdynamic circulatory state is seen with burn injuries greater than 40% TBSA. Increased level of catecholamines, glucocorticoid, glucagon, and dopamine lead to a catabolic state. The altered metabolic state begins within days of burn, which may persist for several years post-burn. The main goals of nutritional support in critical burn patients includes to maintain body mass, prevent starvation, and specific nutritional deficiencies, restore visceral and somatic protein loss, and avoid or minimize complications associated with enteral and parental nutrition. Let's move on to the nutritional assessment. First, anthropometry measurement, which includes height, pre-burn weight, and BMI. Biochemical abnormality found in burn wounds patient is total protein and albumin. Total protein is low because protein have been lost through damaged blood vessels. Second, low sodium and high potassium level occurs because of increased vascular permeability, oozing of plasma from injuries, thus increasing somatic pressure in burn tissue shifting of fluid cell edema. Potassium level increased because of massive tissue necrosis, breakdown of red blood cells. Next, blood urea nitrogen. This is the breakdown of products from protein and also reflect the kidney damage. Fourth, red blood cells are slightly low as the hemoglobin due to the trauma of the burn. And the last one, white blood cells. White cells in the blood are elevated during inflammation and trauma. Neutrophils have fight infection and are the first to side with inflammation. Food nutritional related history include diet history, which is inadequate energy and protein intake, use of medication, and current use of alcohol or illicit drugs. Focus nutrition physical finding. It has been found that burn wound patients will experience high temperature, low blood pressure due to loss of fluids, coughing, difficulty in breathing, nausea, and vomiting. Other than that, we will also examine depth of burn and total body surface area of burn using Wallace rule of nines. Next, let's move on to nutrition diagnosis. It is diagnosed for burn patient to have an increased nutrition needs related to the increased demand of protein for wound healing as evidenced by muscle wasting and low level of serum protein. Secondly is inadequate energy intake related to a decreased ability to consume sufficient energy as evidenced by weight loss of more than 5% in a month. Next is nutritional intervention. Promote adequate energy intake to prevent weight loss of greater than 10% of usual body weight. by advising the patient to consume high-calorie and nutrition-dense food to obtain sufficient energy per day. Next is to provide adequate protein to patient based on the recommended of 1.5 to 2 grams of protein. Vitamins A and C should be advised to consume as they promote wound healing and increase immune function. Consider enteral nutrition for patients if oral intake is insufficient as early as the first 24 hours. Lastly is the nutrition monitoring and evaluation. For anthropometric measurement, the dietitian needs to monitor and maintain patient weight so it is within 5 to 10% of pre-burn weight. Biochemical outcome is to monitor patient proteins and albumin level as well as their sodium and potassium level. For nutrition-focused physical findings is to promote optimal wound healing, to minimize risk of complication, and to minimize the metabolic disturbance during the treatment process. For FNRH, dietitian needs to provide nutrition via enteral route within 6 to 18 hours of post-birth injury and to ensure patient is able to tolerate the recommended energy and macronutrient requirement. Here is a list of reference used in the video. Thank you for lending your ears.